Okay, as we get towards the end of the talk now, I'd like to just briefly talk about what I've done. After I started using these devices in 2012, I realized that the need in hip replacement is even greater. When surgeons do knee replacements, you'll be happy to hear we're accurate about 90% of the time. It's only about 10% that we miss the target. And what is not well known is that when you have a hip replacement, 50% of the time when we try to put in this acetabular piece, even the best surgeons in the world, studies out of Stanford and Harvard, show that the best surgeons cannot put that device in within about 10 degrees of where we want to put it in both planes. And what that means is, instead of having your hip replacement for hopefully 30 years, that you're going to have situations where they wear out 5, 10, 15, 20 years earlier than they should. The other problem, which is known, is that you can have a leg that's too long or too short, which in part is related to this piece and in part is related to the femur. And the other problem that people have heard of, which does happen, is dislocation of the hip. And if we can put this part in properly, about 60 to 70% of the dislocations that we have can be reduced by instruments that do that. So I came up with devices that can do this, and as Gene alluded to, these have been tested by people who look like we're going to be able to hopefully have this as an option. That a lot of people have heard of robotic technology, and St. Joseph's does have a robot that can do this, but the problem is that it takes your surgeon about 20 to 30% longer to use a robot, and it's much more expensive, and that is something that we think we are going to compare favorably to, and I look forward to hopefully having in the years ahead patients that will benefit from this technology. So with that, I've given you a lot of information in a short amount of time, and I'm really appreciative that I have had your attention, and I'm happy to answer any questions.